my name is Richard Fury, and my passion is to take care of patients with lupus. And about 15 years ago, we got interested in drug development. There's no doubt that we need better drugs for lupus. We need safer drugs for lupus. Lupus is a tough nut to crack. So what I'd like to do in the next 40 minutes or so is tell you about therapeutics for lupus and then end with some of the new therapies and therapeutic approaches. And then after that, Laura Donahue is going to talk to you about clinical research and clinical research programs in our division. So this slide shows a couple of the different types of rashes in lupus. On the left is the typical sun-sensitive, the photosensitive rash. And on the right-hand side is discoid lupus. One of the major differences is that the photosensitive rash on the left does not scar. So someone goes out in the sun, they'll turn bright red, and then out of the sun, it will generally heal. Sometimes they need a little steroid. But the rash on the right is discoid lupus, and it has a predilection for the scalp, for the ears, and it can leave a scar. And the scar can be hyperpigmented, so a dark pigmentation, or loss of pigmentation. And you see that over here, both hyper and hypopigmentation. Here's another manifestation. This is vasculitis. So inflammation of the small blood vessels in the hands, leading to loss of blood supply to the fingers. And when that happens, the fingers can turn black and the tips can become gangrenous. Here's a picture of arthritis. On the left-hand side, you can see deformity in the hands. And on the right-hand side, an x-ray showing the actual deformity, seeing how the fingers kind of drift to the right-hand side. Anybody know what this is? Looks pretty, right? It's a glomerulus. So what is a glomerulus? It's a filter in the kidney. And we all have millions of these little filters. This particular filter is stained, and you're looking at it under a microscope. And the stain is showing antibodies, anti-DNA antibodies, which are the hallmark of lupus, as well as complement. So this is called immunofluorescence, and this is a tool that we use to look at the kidneys of patients with lupus. Also, we'll use this sometimes to look at the skin. So these are different manifestations: skin rashes, arthritis, vasculitis, nephritis, kidney disease. And here's an x-ray of someone's hip. The hip joint is a ball and socket joint. So the ball should be normally a ball. It should be round and it sticks into a socket. But if you can see, there's an abnormal shape to that ball. And this is called osteonecrosis, also known as avascular necrosis or aseptic necrosis. And it's not typically a complication of lupus. It's a complication of steroids. So we not only have to watch out for the manifestations of active lupus, we have to watch out for the complications of the drugs that we use to control the manifestations of lupus. Here are two cases, and this just emphasizes the fact that no two lupus patients are alike. As an example, in case one, it's a 22-year-old white female who has fatigue, has a photosensitive rash, so the butterfly rash on the cheek, that's a malar rash, arthralgias, which is the medical term for joint pain, adenopathy, which is the medical term for swollen lymph glands, typically in the neck or under the arms. The blood test, the ANA, anti-nuclear antibody test, is positive. The patient also has antibodies called SSA antibodies. And this particular patient got better with anti-inflammatory drugs and a little Plaquenil. But case 2 is a little bit different. Case 2 is a 22-year-old African-American female who also has fatigue, but has hair loss, that's known as alopecia, a scarring rash in the scalp and ears like I just showed you, that's discoid lupus, high blood pressure, true arthritis, nephritis, meaning kidney disease, positive blood tests for anti-nuclear antibodies and anti-DNA antibodies, and low complement. So those are the blood tests that we check in our lupus patients. The patient's also anemic, meaning a low red count, and thrombocytopenic, which means a low platelet count. And platelets are cells that are responsible for forming clots. So you need platelets so you don't bleed. But this particular patient, unlike the first patient, did not respond to high doses of steroids and did not respond to mycophenolate mofetil, MMF, which is CellCept. And this patient is facing dialysis in the near future. So it's very unusual to find two lupus patients that are alike. They may share some features, but if you go through all the features, usually patients are somewhat unique. So how do we control lupus? What are the goals of therapy? And this may sound very basic. Do good and do no harm, but I'm always emphasizing this to our trainees because sometimes they try to do too much good, and in doing too much good, they inflict some harm. So what are the principles? Control disease activity, and we'll get into that in a little bit more in a little bit. Prevent damage from the disease. So damage can occur in two ways. Damage can occur from the disease itself, or it can occur from the drugs that we use to treat the disease. And of course, try to prevent flares. For some patients, they have a stepwise progression, a stepwise accrual of damage, meaning they'll have some event, the disease will come under control with medicine, and then a year or two later, they'll have another flare and more damage. So we want to try to prevent flares. So that's the do good. Do no harm. What do I mean by that? So prevent damage from treatment. And I'm going to tell you a little bit about the damages from treatment. And most important, do not treat damage with agents intended for active disease. So what do I mean by that? So say someone has had discoid lupus that is no longer active, but they're left with some pigment changes in their skin, they're left with a little scar. You could throw as much prednisone in a pharmacy at that patient, but you're not going to get rid of the damage that it's inflicted. And we always have to remind not so much rheumatologists, but other doctors, that damage does not respond to therapy.